Let us learn orthopedics. Today we will be learning about Colles fracture. Colles fracture is also called as Porteous fracture in many parts of the world. Abraham Colles, an Irish surgeon from Kilkenny, he first described it in the year 1840. Now if you want to define Colles fracture, so it is not just a fracture of lower end of radius, but it's a fracture dislocation of inferior radioulnar joint. The fracture occurs about 1.5 inch proximal to the carpal extremity of the radius. Following this fracture, some deformity will remain throughout the life, but the pain decreases and the movement increases gradually. The common mode of injury is fall on an outstretched hand with the wrist in dorsiflexion ranging from 40 to 90 degrees. On an average, it's usually the 60 degree of dorsiflexion, which results into the Colles fracture. Now, the force required for Colles fractures to occur in females is very much less because of their osteoporotic bones as compared to males. So, the force required to cause this fracture is about 192 kg in women and 282 kgs in men. Now, if we look at the fracture pattern, it's usually sharp on the palmar aspect and there is a comminution on the dorsal surface of the lower end of the radius. Now, the clinical presentation as far as is concerned, usually the patient is an elderly female in her 60s. Of course, even patient could be a male, but mostly it is an elderly female in her 60s, and the history given is a trivial fall on the outstretched hand. Now, in our Indian scenario, usually these fractures are sustained by the geriatric patients early in the morning, the early morning hours when the bladder is full and they want to go to a toilet, and usually the path to the toilet is very ill illuminated. We all want to save a lot of bills in the electricity, and the person gets tripped in and he has a fall and resulting into the Colles fracture. Now, the patient complains of usually the pain and swelling around the wrist, a deformity, and usual other features of fracture at the lower end of the radius. Though the dinner for deformity is a classical deformity described in a Colles fracture, however, it is not found in all cases. It's only seen if there is a dorsal tilt or dorsal rotation of the distal fragment. Now, why it happens so? Because most of the time somebody who is standing nearby, he finds a deformed wrist, so he tries to pull and correct the deformity. So by the time the patient comes to you, maybe the classical dinner for deformity has been corrected by someone. But the styloid process test, is what? If we look at this, a normal correlation between the radial styloid to that of ulnar styloid, you will find that normally the radial styloid lies distally as compared to the ulnar styloid. But in the Colles fracture, because of the impaction of the fragments, you can see now both the styloid processes are lying at one level. Now, the passerby person who is not aware about the impaction part of the Colles fracture cannot restore back this relationship, and that's why often we may not get the dinner for deformity, but we will always find the styloid process test positive, and that's why we say that the styloid process test is more reliable. Now there are 6 classical displacements described in a Colles fracture, and they are namely the dorsal displacement 1, dorsal rotation or tilt 2, lateral displacement 3, lateral rotation or tilt 4, then the impaction, and finally the distal fragments get supination. Now, the dinner for deformity is also sometimes called as a silver fork deformity or a spoon-shaped deformity. As I have already discussed the styloid process test, the radial styloid is lower by 1.3 centimeter when compared to the ulnar styloid process. Now, in Colles, both the ulnar styloid process, they lie at the same level and they are found in all displacement of the Colles fracture. And to perform this styloid process test, you simply need to pronate the forearm using both the index fingers put on each of the styloid processes. Then you can compare the levels. And hence it is a more reliable sign. The styloid process test is a more reliable sign than the dinner fork deformity, because you need to note it that dinner fork deformity is seen only when there is a dorsal displacement and dorsal tilt in the Colles fracture. Now you need to note these: dorsal displacement and dorsal tilt causing dinner fork deformity. Now once you have clinically diagnosed a case to be a case of Colles fracture, we need to confirm by advising the radiographs. Now while writing for the or prescribing for the radiograph, we need to remember one thing. We will prescribe a radiograph of a wrist joint with distal forearm, PA view, not AP. Please remember here it is we are advising posterior anterior view and a lateral view of the affected wrist. Now, why PA view? Because keeping the forearm in that particular position is easier than keeping it in AP view. And secondly, whenever you are supinating the forearm, the ulnar styloid process will go posteriorly, whereas in PA view, ulnar styloid process, as you can see here, is lying on the ulnar side. And that is why it has been made a standard prescription whenever we want to take a X-ray of wrist joint. So we will write X-ray, PA view and lateral view. Now what is to be seen? Now in PA view, what you see is a metaphyseal comminution, and we will also look for whether the fracture is extending into the inferior radial nerve joint or if it is extending into the radiocarpal joint. Now usually in 60% of the cases we may also find the fracture of ulnar styloid process. In lateral view, the points to be noted are the dorsal displacement of the distal fragment along with the dorsal tilt and the sharp palmar edges and dorsal comminution, and as well we should also look for the inferior radial nerve joint, whether it is subluxated or not. Now coming to the classification of Colles fracture, contrary to the popular belief, the Colles fracture is both intra-articular as well as extra-articular and not simply extra-articular only. So the Frykmann's classification, which is most popular, it takes into consideration both the intra as well as extra-articular radial fractures and the fractures of ulna. So as you can see in this particular table, he has classified into 4 important groups. The first is extra-articular, second is intra-articular involving radiocarpal joint only, Third is intra-articular involving distal radioulnar joint only. And fourth is intra-articular involving both the radiocarpal as well as radioulnar joints. And each group is further subdivided into two depending upon the absence or presence of the ulnar styloid fractures. Now this particular diagram shows the extra-articular Colles fracture, the subtype 1 without the ulnar styloid fracture and subtype 2 with the ulnar styloid fracture. Now the type 3 and type 4, they are the intra-articular fractures with the radiocarpal extension. You can see the fracture line extending into the radiocarpal joint. Now the type 3 is with intact ulnar styloid process. Type 4 is with the fracture ulnar styloid process. Similarly, type 5, type 6, here the intra-articular Colles fracture with the extension into the radioulnar joint. Type 5 without ulnar styloid fracture, type 6 with ulnar styloid fracture. And finally, the intra-articular Colles fracture having extension both in the radiocarpal joint as well as the radioulnar joint. So the type 7 is with intact ulnar styloid process and type 8 is with fracture ulnar styloid process. Now there are 4 other classifications available to classify the Colles fracture, and they are namely Gartland and Verles classification, Lidstrom's classification, Nielsen-Lai classification, and Older's classification. Coming to the treatment modality, we must remember the aim of the treatment. The aim of the treatment is to restore fully functional hand with no residual deformity. The treatment methods include the conservative methods, the operative methods, and the external fixators. Now, in conservative methods, the fracture reduction can be carried out by the closed means under either a general anesthesia or a local anesthesia. Now you can see in this particular picture, a hematoma, fracture hematoma is being injected with a solution of xylocaine. So we call it as a hematoma block. And later, once the part is anesthetized, you can undertake the close reduction. Now during the close reduction, the examiner holds the hand of the patient as if he is shaking the hand with him. Now the assistant giving a counter traction by either holding the forearm or the arm. The examiner gives a traction in a line of forearm. Now here you must observe one thing, that he is holding only 3 fingers, not the little finger. It prevents the curvature of the arching of the hand. And once the traction against counter traction is given, the fracture is disimpacted, and once the fracture is disimpacted, as you can see, now he is using both the hands at the lower end of the radius to correct the various displacement of the fracture. He is not simply bending at the wrist, he is pushing at the lower end of he is manipulating the lower end of the radius. Now once the procedure is completed, then again the styloid process test is carried out to check the accuracy of reduction. If the level of the styloid process is restored back to normal, it indicates that reduction has been achieved satisfactorily. And then once the satisfactory reduction has occurred, then limb is immobilized, mainly the Colles cast, and a check X-ray is taken to find out the reduction. The plaster cast is removed after 6 to 8 weeks, and then the physiotherapy is begun. Traditionally, The Colles cast is a below elbow cast given in supination, and ideally it has to meet the following 4 criteria. 1. It must have a firm fit at the dorsum. It must have a firm fit at the volar fracture apex. It should just snugly fit at the forearm, and the metacarpophalangeal joint should be free to move. Now you can see in this particular picture, ideally to put such a cast, you need almost 8 inches wide plaster of Paris slab. Now traditionally the below elbow cast was given or recommended to treat the Colles fractures occurring in senile age group, with an idea to avoid elbow stiffness occurring due to above elbow cast. Now in this particular picture you can see how because of the dorsal displacement, the dorsal soft tissue becomes kinked here, relaxed here, and the volar soft tissue has been broken. And when you do the palmar flexion, how it gets reduced, right? Now, whenever you come across a young active age group patient with the Colles fracture, so you must first give the above elbow Colles cast with the forearm in supination for 3 weeks, and later convert it to the below elbow cast for 3 weeks more for mobilization of the elbow joint. Now giving the forearm above elbow cast with forearm in supination, it will prevent the redisplacement of the fracture inside the POP cast. There are people who are using sonography to guide for the accurate reduction, which is the radiation free and a simple tool. Now the common causes for the failure of the reduction are incomplete reduction of the palmar fracture line and a severe communication dorsally. Now, do you know what is the acceptable limits of Colles fracture after reduction? A dorsal tilt of less than 10 degrees and a radial shortening of less than 5 mm. The next method of treatment of the Colles fracture is obviously the operative methods. So the operative method is rarely required for the Colles fractures, and it may be required in the following situation only. 1. Whenever there is extensive combination. 2. Whenever there is extensive impaction. 3. Median nerve entrapment. And 4. Associated injuries in the adult. Now, depending upon the degree of combination and the intra-articular extension, one of the following surgical method is chosen. The first method chosen is the close reduction and percutaneous pinning with the K wires. After the close reduction by the usual method, the fracture fragments are held together by the percutaneous pinning by 1 or 2 K wires. The arm control method, here this method known to prevent the collapse and gives a good results, as I have already discussed, giving a POP cast, above elbow POP cast. Now, why the percutaneous K-wire fixation is becoming so popular? Because it is very simple. It prevents redisplacement. It always needs, however, an external support. Don't just think that you have transfixed the fracture using a K-wire, it means you do not require plaster. It's not like that. After a regular close reduction, we are transfixing the fracture to make it more stable, but it does require an external support. And for using the transfixion, we must remember that one of the cortices should not be comminuted. Preferably, we must use 2 pins, one from the radial side and another from the dorsal side. Now, while inserting those pins, we must avoid to injure the radial sensory branch and the tendons on the dorsal aspect. Now the third mechanism is doing an open reduction in certain fractures involving the rim of the distal articular surface, that is Barton's variety. Open reduction and plate fixation using the elite plate is advocated. Nowadays the interlocking pre-bent plates are available for the fracture fixation. Now the indications are same as for the external fixation and for the marginal volar or dorsal Barton fractures. The advantage of open reduction and internal fixation are that it provides a good buttress, it resists compression, it's a lower load sharing, and you can always go for early mobilization after the internal fixation. The last module of treating the Colles fracture is use of external fixators. Now these are found to be extremely useful in highly comminuted fractures, unstable fractures, compound fractures, and bilateral Colles fractures. Now through a lightweight Umex frame, two pins are placed in a forearm, here you can see, and two pins are placed in the metacarpal bones. Now these pins are fixed to the external frame and the fracture fragments are held in position by ligamentotaxis. Now the frame should be applied after obtaining a close reduction by the usual technique. Now the Chinese finger trap is also available. The close reduction and the finger trap traction is found to ensure better reduction and a lower rate of redisplacement than just the manual manipulation. Coming to the complication part, there are 6 early complications and 6 late complications as shown in this particular table. Now the early complications include 1. The unstable reduction, 2. Medial and ulnar nerve being stressed, 3. Post-reduction swelling, 4. Compartmental syndrome, 5. The anesthesia problems, and 6. Injury to the proximal segment of the bone while manipulating. Similarly, the late complications include malunion, rupture of extensor pollicis tendon, Sudex osteodystrophy, frozen shoulder, carpal tunnel syndrome, and non-union. Now let us see the malunion. Again, malunion is the most common complications of the Colles fracture, and there are 6 important causes for the malunion, and it includes improper reduction, improper inadequate immobilization, comminuted dorsal surface, osteoporosis, recurrence, rupture of distal radioulnar ligament. Let us see in some detail. Improper reduction. Now if the fracture is not reduced properly, particularly an inexperienced surgeon or just a postgraduate student in the Department of Orthopaedics, so he may not be able to reduce it properly, and it may result into the improper reduction leading in the initial stage, which may cause the malunion later. The second cause is improper and inadequate immobilization. Now you must have done a proper reduction, but you have forgotten to give a proper length of the POP cast, and that is why it results into the malunion. Sometimes you might have given a you might have done a good reduction, you might have given a proper plaster, but the patient was over smart. He goes home, he finds that now after 7 days there is no pain, and he wants to go out, and he himself removes the plaster at home thinking that there is no problem at all. It will result into malunion. The third common cause for the malunion is the comminuted dorsal surface. Now, usually in the osteoporotic bone, there is a lot of dorsal comminution, and because of the extensive comminution, the fracture collapses and recurs after reduction and casting. Osteoporosis again may lead to collapse and recurrence. Then recurrence, again somebody falls, leading to the extensive comminution and osteoporosis. And finally, the rupture of distal radioulnar ligament. Now, this usually goes undetected in the initial stage of the treatment and is responsible for the later recurrence. Now, how to treat malunion? Again, there are 6 options to treat the malunited Colles fracture. The first option is no treatment. No treatment is required if the patient has no functional abnormalities. Second option is remanipulation. If the fracture is less than 2 weeks old. Sometimes the patient doesn't come immediately after the fracture. He may visit you after 2 weeks, and in such situation it is going for a malunion. Better you try to do remanipulation. Third option is Dirac operation. Now, Dirac operation is nothing but resecting the prominent ulnar head subperiosteally, keeping the periosteal sleeve intact. Now, this Dirac operation is more often indicated if the patient complains of functional disability. And the fourth option is corrective osteotomy and grafting if the patient wants cosmetic correction. And mostly when the patient is young, say for example a young lady having a malunited Colles fracture, she is more concerned with the cosmesis than the function. And hence, depending upon what is the residual deformity, whether it is because of the dorsal displacement or whether it is because of the lateral displacement, the 2 types of osteotomies have been described. One is Fernandez and another is Campbell. So for the dorsal displacement, we need to do the Fernandez vase osteotomy, dorsal vase osteotomy, and for the lateral displacement, we need to do Campbell's lateral vase osteotomy. And finally, the 5th option remains is orthodesis. For the intra-articular fracture, when the patient complains of pain in the wrist joint due to the traumatic osteoarthritis following an intra-articular fracture, and in these patients, the wrist in a functional position means slightly dorsiflexion position, is a surgery of choice. Now, and the 6th option is the combination of those surgeries like Dirac operation along with osteotomy, etc. is also tried in some situation. Now, Dirac operation is the most common surgery done in the malunited Colles fractures. It improves the function more than the cosmesis. Still, the Dirac is preferred because the Colles fracture usually occurs in elderly women for whom function is more important than the cosmesis. However, if the cosmesis is the priority, the corrective osteotomy has to be done at the radial fracture site, which will give the good results. And hence, for deciding the line of treatment in case of the malunited Colles fracture, most important thing is we need to ask the patient whether he or she is interested in functional recovery or a cosmetics or both, and then we can choose the correct treatment option. Now, another complication is the rupture of extensor pollicis tendon. Now, this occurs due to the attrition of the tendon as it glides over the sharp fracture surfaces, and as you can see here, and usually this occurs 4 to 6 weeks after the fracture has occurred. It may be repaired or left alone without any residual disability. Another complication of the Colles fracture is Sudex osteodystrophy. Now, this is due to abnormal sympathetic response, which causes vasodilation, as you can see, the swelling here, and osteoporosis at the fracture site. The patient complains of pain, swelling, painful wrist movement, and red, stressed, shiny skin. You can compare the normal side along with the diseased side. Now, the treatment of this condition consists of immobilization of the affected part with the plaster of Paris plate, injection of local anesthetics near the sympathetic ganglion in the axilla, or the cervical sympathectomy in the extreme cases. Finally, the last complication, the frozen hand-shoulder syndrome. Now, this is a troublesome complication which develops due to unnecessary voluntary shoulder immobilization by the patient on the affected side for the fear of fracture displacement. It is said that the patient has performed a mental amputation and kept the limb still. And sometimes the malunion of the Colles fracture crowds the carpal tunnel and result into the compression of median nerve, causing carpal tunnel syndrome. Non-union. This is extremely rare in Colles fractures because of the cancellous nature of the bone, which enables the fracture to unite well. However, sometimes the soft tissue interposition may cause this problem, and obviously the treatment consists of the open reduction and internal fixation, rigid internal fixation, and the bone grafting. And thus, we can call the Colles fracture as a fracture of 6. Why? Because the Colles fracture is common at 60 years of age. The forces required to cause Colles fractures are multiples of 6. There are 6 classical displacement. There are 6 methods of fracture immobilization. There are 6 weak immobilization is required. There are 6 important early and late complications, 6 causes for malunion, 6 methods for managing malunion, and 60% of the cases have fracture ulnar styloid. That is why we can call fracture Colles as a fracture of 6.